A very good morning to all of you. I, Dr. Gautam Badole, on behalf of Department of Conservative Dentistry and Endodontics, VSPM Dental College and Research Center, Nagpur, welcomes you to the E-Link Fest 2020. We will be having the webinars daily for the entire month of July. Today, on the 9th day, we are privileged to have an eminent speaker, Dr. Anuj Bharadwaj sir, who will be speaking on the topic There is more to your teeth than meets the eye. We welcome you, sir. We are also honored to have with us a well-known personality in the field of endodontics, Dr. Pradeep Jain, sir, who will be moderating the today's session. We welcome you, sir. A warm welcome to all the participants. Before we begin, a kind request to everyone to please mute your mics and switch off your videos throughout this session. For any queries, kindly put the message in chat box, which will be answered at the end of this session. The live session will also be available on our Facebook page, Endocons VSPM Nagpur. Now I take this opportunity to introduce our moderator for today's Dr. Pradeep Jain, sir. Sir is the professor and head and PG guide, Department of Conservative Dentistry and Endodontics, SAIMS College of Dentistry and PG Institute, Indore. Sir has completed his bachelor's degree from the College of Dentistry, Indore, and master's from Government Dental College, Amritsar. He was past vice president of IACD and EC member of IES. Sir has got various national and international publications to his credit and has presented numerous scientific papers. He has conducted various hands-on courses and workshops on basic and advanced endodontics. He is South Asian Advisory Board member for Elsewhere and has contributed in the textbook of operative dentistry by Studovan 5th edition and the Pathology of Pulp by Cohen 9th edition. Now I request Dr. Pradeep Jain sir to introduce our distinguished speaker of today's, Dr. Anuj Bharadwaj.
Before I actually start, I don't think Anuj needs any introduction, but since it is what is important is that all the audience should know about the speaker. So it's my humble effort to introduce him to all the audience. Before I introduce, actually, I would like to congratulate the entire team of E-Link Fest 2020 for doing this commendable academic session, and that is 1 hour, 1 month. Every month there is 1 hour session will be kept on this. And thank you, Fatima, and the entire team for giving an opportunity to share session. Today we have with us Dr. Anush, my younger brother, my friend, and my colleague also. I was working when we were working together in and it's an opportunity for to use Dr. Anush to all the audience. Dr. Anuj, he is an MDS both, especially MDS good medalist. He is a diploma of Indian Government Economics, Professor College of Medical Sciences and Hospital now in Indore. He is an additional faculty Department of Dentistry, Universities of Erlanga, Indonesia, Director of District Training Academy in Indore. Director in Indore. Is certified for advanced training in micro dentistry. Is graduated from Magnification College, Hospital, Bangalore, which is affiliated with diabetes. Post-graduate MBS from Meenakshi and Dental College, Hospital, Chennai, Tamil Nadu, and he has been invited as guest for more than 70 scientific events at national and at national and the international platforms. He's received many awards. Best Scientific Poster Award in the FODI and IES National Conference 9. First prize who is in I4 that is Murthy Dental College, Amalai. Second place who is in the IS and FDI Conventional Conference 10 Chennai. Second place David Stewart in Anthony 2012. And he has got various national and international publications to his credit. And the special area of interest is most important to my is very wonderful on magnifications. I think it's really started to and advanced microscope training from Germany. He has got as IS, then microscope advanced conservative dentistry, lasers in dentistry, and last but not the least, the implantology. So, Anuj, Dr. Anuj, I would like to welcome you for such a wonderful session and thank you for accepting the invitation on behalf of Dr. Pratima Shinoy to organize such a wonderful lecture. Thank you so much. You can start now.
Yes. Thank you, sir, for this wonderful introduction. Can I have the share screen option? Yes. Okay. Am I audible to all of you without any echo?
Yeah, it's quite clear, Dr. Anuj.
Okay. No
Yes.
echo, right? I hope there's no echo.
Yeah.
No.
Okay. A very good morning to one and all, to all the respected seniors, colleagues, juniors, students, and friends. I would first of all like to thank Pratima Shinoy ma'am and sir for inviting me to this platform, that is eLink Fest 2020. It gives me an immense pleasure to be a part of such a big platform and to be speaking with mentors whom I always look up to. Thank you again, ma'am, for this. And another thanks is for having Pradeep Jain sir chair my session. I've learned a lot with sir, and I've worked in different platforms and ways with sir. It's always a pleasure to be working with sir. It's great that he's going to be chairing my session today. So to start off with today, my topic is going to be there's more to your teeth than meets the eye. So what do I want to say by this? This is for every practicing dentist, every postgraduate, and every senior dentist, that we should not forget this. You can only treat what you can see. And this was a statement which I read in 2008 when I just joined my post-graduation in Meenakshi Ammal Dental College. And there was this article by Singhu Kim. And this statement changed my perspective towards dentistry. During my undergraduation, I was an average student. But after this statement, I would not say I became a better student, but yes, my approach, my thinking towards dentistry, my passion towards dentistry changed completely. How did it change? What are the questions raised in my mind before I could get into magnification was, these were the three questions which I'm sure all of you must be going through, whether you are just a graduate, you've just finished your graduation, you're an intern, second year, third year, or a postgraduate. And especially I would say this to a postgraduate, these are the questions which run through your mind. Why should we adapt to magnification when I'm already doing well? And then there's a next question that once you join post-graduation or you've done enough of practice, you've started to feel that there is nothing new happening in your dentistry, there's nothing new happening in your practice. Why don't we adapt to magnification? This is the question which comes next. Last but not the least, why should I adapt this so that I have edge in my practice? So is this magnification going to give me an edge in the practice? So sooner or later during this presentation, I'm going to address to these questions one by one, and I hope I'll be judicial enough to answer them the way I would want them to be answered. So what's the focus going to be today? So our first focus is seeing what we are doing. So let's talk about resolution of our eye. What do I mean by resolution of our eye? This means that if two dots are kept 0.2 mm apart, they would look like one dot to you. And most of the work which we do in endodontics or anything inside the tooth, that's why endo, inside the tooth is within the range of zero point 0.1 to zero point 0.2 micrometers. So if you're not able to see those minor details, you are not being justified by doing your work. Yes, you're getting results, that's fine. But then if you could get results which you can actually promise to your patient that, yes, this is the treatment outcome you're going to get if you get the treatment done by me using this and this devices. So that's going to help you improve your practice. So if you see two dots kept 0.2 mm apart, they look as one. How do I make this better for myself? How do I make things more clear during my work schedule or during the day when I'm working? So this is Mahatma Gandhi ji on an Indian currency note. What I would want you people to have a closer look at is at the spectacles of this image. And just imagine if I was seeing this under magnification. So how is it going to improve? Why I'm saying this, the things are going to improve is, if you see here, I have highlighted that with unaided vision, you can see only 0.2 mm dots as one. But as you increase in magnification by 2 times, 3.5 times, 5 times, 10 times, and 20 times, you can see two dots which are kept 10 micron meters apart. So is this going to help me or is it not going to help me? So let's see it. So here is the power of magnification on this Indian rupee note. So the first row shows you total magnification and the second row shows you field of view. So as I'm increasing the magnification from 3.4x till 21.25x, leave the frame of Mahatma Gandhi ji in this image. See the pupil. You can see each and every dot which is very clear to you. So if there is any micro crack or if there is any orifice opening which is as small as 0.2 to 0.1 mm, I would not just take an ultrasonic or a slow speed handpiece burr and run and rub around it. When I'm doing that, I would be able to visualize it. So for instance, here is an example of doing your diagnosis when you're checking for dental caries. We all know that we are shifting from crude way of doing dentistry to minimal interventional dentistry. So if you see the first image, that's how it looks in the mouth mirror to us with our naked eyes. And the next two images are under the loop. And the last four are under the magnification. So in magnification, what am I able to see is these grooves and fissures look like a huge valley to me. And when I see them, I'm able to see which is a carious part and which is a discolored part. So I'm not going to take any sharp instrument. I'm not going to take a probe and go probing the area and check for a catch, because we know we are moving from a demineralized to remineralized tissue era. We can remineralize these demineralized tissues. But if you are poked it with a with your pointed instrument, there is no getting back from there. And that means you are not justifying your treatment. You're not being at par with the technology now. So you need to analyze why we are stressing on magnification nowadays. So now there are two kinds of people which exist. One kind of people are people who try to find solution to every problem. And then there is the good ones who find a problem in every solution. They think that, yes, I don't want to have to move ahead. I'll just stick on to this basics. I'm not going to get solution to this problem. But then if you want to be a diamond merchant, for us, diamond is the tooth and we are the merchants. So we will be dental merchants. If you want to know how good or bad the tooth is going to behave or is going to react later, you have to have an eye for it. So how do you have an eye for it? It has to be a magnifying device, which makes you see all the intricate details. And if this wasn't enough, or if it wasn't enough, I am really sorry to say that yes, physiologically, we are going to age. And once we age, we are going to have something called as visual acuity. As a youngster and being in your middle 30s and just reaching your 40s, you would say, I'm having 6 by 6 eye vision. I can see anything. You name it and I can see it. But then physiologically, what happens to your eye is presbyopia. Now, what do I mean by presbyopia is with age, the lens which is there in your eye begins to stiffen up, and the focal point which is supposed to be focused at the retina gets pushed back. So if you see any senior dentist or any senior person who's trying to read or see a mobile, lived only dentist, what they do is they keep the object here and they tend to move away. So they're just trying to accommodate this reflex or this physiological uh, process which happens, just presbyopia. But then how can this be corrected? Do we have any solutions for it? Let's talk scientifically. So there's this article by Perrin et al., which is published in Swiss Dental Journal in 2016, where they check about visual acuity and magnification devices in dentistry. It's a review article where they have compiled around 214 plus 14 articles. They checked on PubMed, came to a conclusion of 223 articles, and then checking the abstract inclusion criteria, they could only cut down to 23. And then when they went into a detailed reading of the article, they had only 5 articles in hand, which could give them the actual information about aging and visual acuity. So what did this article say finally? Younger dentists profit more from the ergonomic aspect, while dentists over age of 40 can compensate their age-related visual deficiencies while using this type of loop. Here they're talking about loops. So this is one part of your conclusion. Now coming to the last part of the conclusion, they say is the optical advantages come at a cost of ergonomic constraints due to the weight of these loops. So that is why I'm not a big fan of loop. I would want people to sooner or later shift to magnification under microscope. So the microscope is highly superior visually and ergonomically, and it is indispensable for the visual control of endodontic treatment. Here today I'm talking more of endo, but if I'm going to be speaking as a general dentist, I would say it's important in every branch, starting from diagnosis till you say bye-bye to the patient. It's that important. So what was my interpretation from this article was that a younger student or a student who is in their second year or third year, if we give them a magnifying device starting from a loop, they would get ergonomically correct. And dentists who are 40 years and above would get over this presbyopia. So what it does is it brings this gap down. So a younger dentist who gets into magnification or gets into magnifying devices will not have any issues later with presbyopia because it's already getting accommodated, and his ergonomics are going to stay well forever. He will not have neck pains and back pains, which is actually the condition which is happening with most of the senior dentists. So we always show articles or references of foreign authors. So there's this one beautiful article published in Journal of Conservative Dentistry, our own JCD, which is by our society, which talks about evaluation of tooth preparations for class 2 cavities using magnifying loops among dental interns and final year students. I'm not even talking about postgraduates. I'm not talking about people who have been doing dentistry from long. So what did this say? Even this said the same thing, that magnification loops have significantly enhanced the quality of cavity preparations done by final year BDS students and interns during their preclinical dental educational work. Last but not the least, always remember to read between the lines. It says, however, more practice with loops is needed for convenience of its use. So whenever you learn anything new, you need to get adapted to it. So if you remember, once you got into dentistry in your first year, you were mixing plaster, you were making 1-inch cube. You were not understanding whether you're here to become a carpenter, a technician, or what. But now, how you have honed your skills from that day till today, you are able to correlate things. Yes, from a crude form, we have gone to more finer form. And from this fine form, I want you to go to a micro level fine form once you start getting into magnification. Then we have, as I told you, we have two kind of people. The second kind of people who still have problems to every solution. They say, no, it's fine. I can work without it. It's doing well for me. Ergonomics. This is one thing which we need to pay attention to. It is basically the study of proficiency in the working environment. And I've been using this slide from over a decade now, since my postgraduate days. But I never thought that there would be a day that I would be dressed like an astronaut and working on patients. All thanks to COVID. Let's get back to business and talk about keeping your neck and back straight. If I have a device which is integrated between me and my patient, which helps me to keep my spine straight, which keeps me fit, which avoids any neck pain or cervical spondylitis or back pain, I am sure we would be more than happy to incorporate it during my practice or your practice. So this is while doing a case in a clinic, whereas this is when we are teaching preclinicals. So the habit has to be inculcated into you during preclinicals. I'm very thankful to my teachers and my guide during my post-graduation that they made sure that we used magnification even while doing our preclinical work. So that's how it changed our perspective and it improved my ergonomics. Because when you talk about ergonomics, this is a disability which is faced by all the people all around the world, and we need to make sure that we have a solution to it. And here is a solution which will help us to improve our posture. To your shock, it's not only students or dentists in India who are facing this issue. It is basically happening all around the world and at various ages. But then you need to understand is when was this put across in articles or when was this cited? This was in 1998 and today we are in 2020. So we are way around 32 years after this was published. So do we stick to this or do we enhance ourselves and move ahead? In Western countries, they already have made sure that any postgraduate who passes out through this specialty of endodontics or conservative dentistry has to give his degree under magnification. And this was made compulsory way back in 2008. So what are we waiting for? We are waiting for some disasters to happen? I would say no, but it is just the laziness in us or the resiliency of being lazy that we are not able to adapt to it. But trust me, with all this various scopes being added to the microscopes, things have become much, much easier than how it was with fixed focal length lenses, which I'll be again talking why we don't get into magnification initial days. But now postgraduates have a better option of shifting into magnification much faster than what we could a decade back. At the end of the day, whether you are a senior most practitioner, young practitioner, a second year BDS student in preclinicals, or a third year young clinician who is getting into practice, at the end of the day, you are in this posture. Whether you like it or not, whether you accept it or not, I say I would accept it before when I was not in my magnifying device as an integral part of my work. So who's responsible for this? It's just you and me who are responsible. So if I'm using a magnifying device, if you see here, my posture, see the red dots being connected. My spine and my neck are absolutely relaxed and straight. As mentioned to you before, we still have people who find problems to solutions. So there's this guy who has this high-end microscope with him, but still does not want to respect his back and neck. So if you stoop even with the microscope on, then you belong to the second category, and there is no solutions for you. So I hope the first part of my presentation, why we should adapt to magnification, is relatively clear. If not, we would be discussing, I would be taking your questions in the question and answer session. So this was the first part of my presentation, why we should adapt to magnification. So next is why we do not adapt to magnification, the second question. So what are the reasons behind it? The reasons is we are not clear what do we want out of it. And we are not clear why we want it. Is it going to increase my expenses? Is it going to increase the time of duration while working on a patient? Yes, it would, provided you did not know parts of a microscope. So whenever I start speaking about magnification, I always want to talk about parts of a dental operating microscope. But then I have resilience from few people who say that we are not mechanical engineers. The machine is supposed to be a machine and we are not supposed to know anything about it. What is the point? It has to be just integrated between me, my patient, and I should start working. It should be just that automatic mode. This is the problem where everyone gets clogged because you're able to see with one eye, you're not able to see with one eye, there is blurring happening, patient moves here and there. When you move the microscope up and down, there are issues. If you have a microscope with fixed focal length, then it becomes a little tough. A tall guy and a short guy using the same fixed focal length lens of 200 or 250 mm. So the shorter guy is comfortable, but for the taller guy, he has to stoop forward and the ergonomics is not taken care of. So this is the reason the second part of my presentation talks about the parts. It's a very small part, but it's very important part. So if you see here, the binocular tube consists of eyepiece and has various prisms added to it. And on top of the eyepiece is where your eyes should rest. Below the binocular tube is the magnification changer. This is a place where you have different prisms for increasing the magnification which is present. So if you're seeing a microscope on the right side and the left side, you have knobs which you can rotate. So if you have a prism one, you'll have to turn the knob and you'll get a clicking sound like tick sound that the prism is got into its place. But if you have a continuous zoom microscope, you can see in between two. Last but not the least is the lower part which has a fixed focal lens, which is changing now. We have something called as varioscope, or Numer technology from Labomed. This gives you a buffer zone of 10 millimeters, which means a lot. That means depth of focus. What do I mean to say by this is if you're focusing at the incisal thirds or if you're focusing on the orifice, if you rotate the knob, you can actually still see clear things when you're going deep down, which was not possible with fixed focal length lenses. Next part, which you need to understand with magnification is light guide. You have a light guide, which is coaxial. You do not have to keep changing the angulation of lights to see what you're working on because it's coaxial. It's going straight to the tooth, coming back from the tooth. And if you're working under your, using your mirror, it's going to the mirror, hitting the tooth, from the tooth, it's reflecting back onto the mirror and coming back to your eye. Now we have three types of lights which are available that are halogen, which was in the beginning. Then then there is your LED lights, you have xenon lights. Halogen lights of late have been taken off from the market. Now we are having only LED lights because halogen light gave you a yellowish tinge, which was not much appreciable by many dentists. But the best part about that was we did not have any eye strain. We did not have any eye fatigue, even if you worked for 7 to 8 hours. But with LED, I feel that if you work for 8 to 10 hours continuously, and if you're using the high illumination or the maximum illumination or the intensity, you tend to get eye fatigue slightly, as well as the color change is not that prominent. Whereas with xenon, it is supposed to be the best. And these are the light sources which are used by ophthalmologists or neurosurgeons or microvascular surgeons because they need a very good contrast between tissues. And as you know, if the higher the contrast, higher is going to be the cost and lesser is going to be the number of hours it can be used. So that is why we have found a way in between, that is your LED light. So before I get into the last two slides of the second part of the presentation, you need to understand focal length of the lens. It ranges from 200 to 300. Plus, if you are a little more taller, you can actually tell the company that I want 350 or 400. You do not have to adjust to what the dealer is providing you. You have to tell the company, see, I am tall, I am 6 feet. I need at least 350. I need 400. What is the point having a microscope and you're stooping and seeing in the lens? There is no point. Second thing is focal length of the tube. Standard is 170 and it can go up till 260. Again, this foldable tube is available in 170 to 260. But foldable tube is again good for people who are tall. They would not want to work with their hands like this. They would want to work comfortably. So they want enough distance between the microscope and themselves. So for that, you will have your foldable tubes. The third is your magnifying factor of the eyepiece. It is available as 12.5x standard now. Initially, it was 10x when the microscope started. So this is not a big thing that you need to know. But if you have an old microscope or you have a ENT and ophthalmic microscope which has been converted into a dental operating microscope, you need to see this, whether it is 10x or 12.5x. Last part, but not the least part, is magnification factor or the magnification changer, which is present on the left and the right prisms. You can keep moving. So every company has their own readings ranging from 0.4, 0.6, 1.6 to 2.5, or 0.3, 0.5, 0.33, 0.69. It varies as per the company. So once you are sitting in front of the microscope, please remember these commandments. This is very important so that you don't start hating the microscope before even liking it. First and foremost, if you see on the left side of my presentation, you can see the readings from 55 to 65 and it goes henceforth. So this is basically for your IPD, it's your interpupillary distance. Most of us are, until it's your private microscope, if you're working in a charitable trust or if you're working in an institution, people will keep changing their IPD. So you need to make sure you've got your IPD tested and checked, and you feed this IPD into this IPD meter, because your IPD does not match with everyone's IPD always. Second thing which you need to understand is, if you go below this, there are two eyepieces. At the eyepieces, if you see on the top, especially the left one, you can see positive on the left and negative on the right. This helps you adjust your eyesight power into it, +6 and -6. Not the complicated ones, but the straightforward ones, far and near sight. That can be put in here, and you can remove your spectacles and start working here. And it is possible to do it to your left eye and to your right eye. Now, the right side of my presentation, or the binocular tube which you're seeing, if you see the two rings are out, this is basically for students or for colleagues who are not wearing spectacles. With the spectacles on, you would put these two rings out, you would rotate them and put it in. And if you are without specs, you would rotate them out and get these two rings out. The reason why I say this is, people who are wearing spectacles are used to seeing straight because they have focused through the lens which is provided into their spectacles. But people who are not wearing spectacles like me, we have a habit of seeing here and there. So when you're working in a microscope, I would want to look right through like this. I would want it to fit onto the eye cups to fit onto my eye like this, rather than having some spaces and I see laterally. It's like a horse view. I want to just see inside. I don't want to see anything laterally. So this is why you will open up these two rings. So if you do these three things and you know what magnification you are working at, you will not hate your microscope. And if you have a varioscope, things are going to be so fast that you can adjust your field of view within minutes. And that is within 1 minute or 2 minutes maximum. It's not going to be cumbersome. And you will be able to shoot at your target and work very nicely. Now, as I mentioned to you about the details which are given or the values which are given on the magnification changer, is actually not the magnifying power. It is the alpha power. Now, how do I decide what is the magnification or the magnification number which I have reached using the microscope which I have and the magnification changer reading? So you have to remember this: the focal length of the tube, which is on the top, divided by the focal length of the lens which is below, into the magnification changer, which you know already, which is going to be 0.3, 0.5, whatever the one you're using, into the eyepiece power. That is going to be your 12.5x. So this is how you're going to come to a conclusion that at lowest magnification and highest magnification of alpha power, I am getting a range of 3.4x to 21.25x maximum, until and unless your focal length of the tube is changed or it has become bigger. So what happens as the magnification increases? If you see here in the rows, magnification factor, total magnification, and field of view. As the magnification factor is increasing, magnification is increasing, and your field of view is becoming narrower and narrower. So if I'm doing this movement to you, is very minimal. But if this is the only movement, if you're seeing through a microscope or through any magnifying device, it's going to be exaggerated movement. As the magnification increases, the more exaggerated your movements are going to be, more exaggerated your instruments are going to look. So you need to control and be calm when you're using these, and you have to train yourself that you don't give these crude movements. You have to train yourself to give minute movements. And as you know, when you're working inside the canal, or if you're doing any instrument retrieval, or you're doing a perforation management, what kind of minute movements your hands have to get used to. You should get over the shivers. And to be honest to you, if you're working under magnification, you can do a movement of zero point 0.5 micron meter, which is actually not visible to our naked eye. But under magnification, you can do this kind of movement. So if this theory was not enough and it was troublesome to you, we have departments having microscope and they're just lying in one corner draped. That's because we are not paying attention to these small details and we want to have direct vision. So once you get used to this indirect vision under microscope and you get this, as I was saying to you, that you become a diamond merchant, no, a tooth merchant. When you value your tooth as a diamond and you know the value of the quality which you can give under magnification, you would never sit in this position. You would have the microscope in between you and integrated between you and your patient. I hope the second part of my presentation, which was about why we don't get adapted to magnification, is somewhat clear to you. If you still have doubts, at the end of the presentation, we will be discussing again this part in question and answer session. Coming to the last part of the presentation, which talks to you about how is it going to improve my vision? How is it going to make my clinical practice better? Because two dots which were seen as one now are going to be seen better to me. So how are we going to make sure that we work well and give the quality which everyone asks for? So let's make a start. Not this kind of start, because dentistry has been evolving, so has magnification. I'm not going to get into history now. I'm not going to talk too much of literature, which I've already spoken now. So if you see this image, this is an ENT microscope which is used for checking the tooth long back. And if I expect people to get into magnification because it was introduced long back, I think I am not being justified, because way back in 1864, S.C. Barnum said, if you use rubber dam, things are going to become better for you. So if people are not ready to evolve to rubber dam, asking for magnification is a little tough. So my humble request to you is shift to rubber dam, shift to magnification. No rubber dam, no magnification, no endo. I would say no dentistry, in fact, because with this pandemic, COVID times, you know, rubber dam is a must, high vacuum system is a must. And if I can have that much of space between me and my patient with the microscope on, it's going to be much, much, much better for me and for my patient. So basically why I want to incorporate this into my clinical practices, because I want to have complete control of what I am doing inside the tooth. And I have to make sure that my clinical practice evolves. And that is how I stand out compared to my colleagues. It's not for social media. It's not for putting up updates on social media and making people happy. It is basically to share the knowledge, because when you learn, it's when then you can teach. So I learned over a period of time, so I'm able to teach today. But if I'm teaching today during the question and answer session, I get to learn again from you. So this is a reversible process. So you learn, you teach, and when you teach, they ask you questions. So you learn again, and then again, you get to teach better. So this is why I like lecturing, to learn more from my colleagues like you. So magnification, why is it needed in my practice? Because it's helping me to see things better. So if I'm able to see things better, I can diagnose better. I have the edge over the others, which my colleagues are not able to see. They tend to send them for CBCTs, or CBCT has its own role. But then I would not be totally dependent on CBCT. CBCT would be my next option. First option would be I see it directly under my microscope. So if I can diagnose better, I can, I will have a better socioeconomic status in my fraternity. Why do I mean to say this, and why do I need this? I need to stand out among my colleagues. I need to see things better. I need to diagnose things better, so that I get better ideas and how to manage this. And if I can get better ideas, and this would happen if I'm able to document. Now, why documentation is very important? I am not talking about medical legal issues. What I am talking about is when my patient walks to me, or if I'm having a session like this today, if I show you cases which are put up in some articles by some fellow colleague or some senior or some researcher, you will like it. You will appreciate their work, but you will not have confidence in me. You will not appreciate my work. But if I want a student or a patient to listen to me and get the treatment done by me, they have to see my cases. They have to see how I managed it, what is the treatment protocol, and how is the clinical outcome of it. So I have follow-ups of it, and then the patient is convinced. It is not that I'm trying to convince them by my talks. I'm trying to convince them with the data which I have on my table, which I have it on my laptop. So people who said magnification is future, I am really very sorry to say it is the present. It's the present which is given to us by God. So please accept it and start using it. And the day you start using it, your life is going to change drastically. So basic goal of doing magnification is to get good clarity and to get good treatment outcomes, and to have, I would say, when you're showing your PG program file or PG program guide to your externals or to your internals or to your colleagues, or once you pass out, you should have these kind of images. And to your surprise, when I had joined the Meenakshi Dental College in 2008, we had 3 dental operating microscopes in our department, in which two were mobile and 2 of them did not have documentation, and one was attached to one chair in one corner, which had all the documentation details. So that is how our department had so many publications on case reports, had so many publications on anatomies, because we could see things better, we could adapt to things better. I'm still on time. I've just taken 40 minutes, I suppose. Yeah. So getting into clinical scenario, but before that, preclinical scenario. So what I want to show you here is inlay cavity preparation, which is done on an extracted tooth as a postgraduate. So if you see this under magnification, you can see there is caries on the groove. You can see the finish lines. You can see the cable surface margin. You can see the floor. It has got burr marks. So if I increase the magnification even further, I can see there is caries even on the floor. Then when we talk about gingival seat, I'm having a little disturbance. Can all of you mute yourself? Thank you. Okay, so now when you talk about the gingival seat, we've been told that this much has to be in enamel, this much has to be in dentine. So if you see here, you can see the burr mark, you can see the crack lines, the unsupported enamel rods. Pradeep sir, I'm able to hear you. Can you please mute yourself, please?
Okay.
Thank you. So sorry. Yeah, thank you. So if you see this gingival seat here, you are able to see the burr marks on the dentine. You're able to see enamel separately. Same thing, I magnify more, and I can see even the enamel cracks seen on the gingival seat on the enamel aspect. So next thing, when I give a bevel to this axiopulpal line angle and the gingival seat on the enamel, you see, you don't see any unsupported enamel. You see a smooth flow. You're able to see how much is in enamel, how much is in dentine. But what I need to see here is on the pulpal floor, there is still caries. So these are the kind of cases which come back to you after 6 months or a year and they say, I paid you X amount for the treatment, but why is it failing? And these are the patients who come regularly for checkups, and they raise fingers at you that what kind of work are you doing? So if during your preclinicals, I showed this to you, you would not say that I went back with the same cavity and my teacher approved it. If you remember, or if you would remember it now as your postgraduates, or whenever you go to your guide or your teacher, they ask for a loop. They ask you for a magnifying glass with a light. That is again a type of magnifying device. They want to see things better, and they tell you to see, but they cannot make you understand because there is no pictorial representation like what I'm showing to you here. So from today, if you get into this magnification, you would understand, yes, this is what was told to me. So the learning curve of experience, which would take me 10 years, would cut short to 5 years. Instead of 10 years, 5 years. So where I have reached today in 10 years, I would be more than happy that if you reach this in 2 or 3 years. And that's when your positive competition increases. That's how your quality of work increases. So let's not talk about preclinicals. Let's get into clinics and discuss few cases before all of you start getting bored. Restorative. Now, in this, I want to share that I have not used any hi-fi device. I've used the same straightforward rubber dam sheet, same straightforward suction tip. I've shifted from a plastic front surface mirror to a metal front surface mirror here now. And if you can see, the amount of reflection which I'm having in this metal mirror is comparatively high to the one which I shift to a plastic mirror. See this, there is no reflection all around. So I would prefer a plastic one over a metal one. And this metal mirror is not having that good reflection. The reason being, it is matte finish. And if you had paid attention to my video from starting, initially I was having my aeroter and mirror at 45-degree angulation so that I can see what I am doing rather than working blindly. Then when I shifted to a metal mirror, I could see some amount of reflection happening at the borders. And then again, what I am doing is I am moving to this ultrasonic tips. So once I'm moving to this ultrasonic tips, see the amount of tooth structure I can see. And my mirror from 45 degrees angulation, it's come to 30-degree angulation. And the tip has so much of space to work around. Now I'm using ultrasonic tips, initially without water, then with water intermittently. And I would have my assistant on my left to have a wipe, which he will keep wiping, because using water and air will not be able to clean it. If you see it in the video there. So now I shift to I'll be shifting soon to a zero size mirror. Now, once I shift to a zero size mirror here, you would see that how much of space I have when I'm working with a slow speed handpiece and a long shank neck burr. When I'm using an LN burr and I'm using a normal 3 size, 4 size or 4 size mirror, I will not have this much space. But what you need to understand is I'm resting my mirror against the rubber dam. So there is no movement. My hands are not having that shiver and the image is clear to me. So these are the small things which if you apply into your clinical practice, you will not hate rubber, you will not hate magnification, you will start liking it. Next case. I'm sure we always have this kissing caries, distal of one and mesial of the adjacent one. So now we've isolated really well. I want to show you a floss tie, how we have inverted the rubber dam. I know that I'm not going to have any leakage of GCF2, but then when I'm restoring the premolar, if you see here, there is a gap between my matrix band and the tooth structure. And this can be taken care of. I'm sorry, I cannot use a pointer here, but this can be done if I have Teflon tape and I take a cord packer and I pack it from the sides. So this gap would close down. But the same thing does not happen when I'm working on the adjacent tooth because I have a wall already against which I can rest. So if you see here in this image, the matrix band adaptation to gingival seat is just perfect. The only flaw which I can see here is if you have an eye of a dentist who considers the tooth as his gem or a jewel, is a thin crack line on the gingival seat. So I would take a slow speed handpiece burr and try to accentuate that groove and see how deep is that fracture going and accordingly treat it. So from the left image to the right image, we have moved. Now the next question should be, why didn't I change the occlusal composite? Because it didn't look defective under magnification to me. And patient was okay with the aesthetics. Or else what I would do is I would remove the whole composite. That's the way I do. And that's how you learn over a period of time that even if the patient is happy with it, you need to have your own terms and conditions. This is in my initial years of magnification. If this patient came to me today, I would say, even though I don't see any issues, the sooner or later is going to fracture. So I would want to repeat the whole thing because I want a mono block filling. I don't want it to have many steps or uncured composite and cured composite or a fractured composite. I would not want to have many interfaces. Coming to endodontics. In endodontics, everyone is in the hunt of extra orifice. I would not say canal, but orifice. But you need to understand that any extra orifice would be smaller than 0.1 mm. And if you remember that resolution of our eye, and we take ultrasonic tape, sometimes most of us don't find it. We take a burr, slow speed burr, few of us are happy with the aeroter and we keep digging and we don't find. And as a beginner, or as we are in our internship or first year of MDS or post graduation, we end up doing a lot of perforation, searching for something new. We get something new, but that's a perforation. So what you need to understand is, if you see the video on the left, see the movements which I am giving, and I'm using a plastic head anechoic front surface mirror, and I'm using a micromotor with an Allen burr or a Messinger's burr here. So I'm just giving these brush strokes from MB mesiobuccal towards palatal, one stroke, just one stroke. And I don't only search for MB2. If you see in the later part of this video, I would be searching even for distobuccal 2. And I don't know what is the shape of the orifice. I would not want to create my own orifice, which is just one big orifice, which I've made two orifices and they're getting confluent. So once I have looked for my MB2, I would move and take my aeroter or my micromotor or slow handpiece to search for a distobuccal. If you see the image on the right, you would see that this is my mesiobuccal 1 and this is my mesiobuccal 2. And they are fusing together and they are at a very low level. They're not at the floor level. They are quite below, 0.2 to 0.3 mm below the floor level. So if I use aeroter, if I use that head, it's going to be very tough for me. I need a long shank burr or a Messinger burr or a Munz burr or an ultrasonic to see what I am doing. The whole point of getting into magnification is to see better. If you see here, as I was telling you, I always look for distobuccal 2 also, and see the way and the precision in which we have got it. We have not dug out anything extra. We are going to be as conservative as possible. And what do I mean by as conservative as possible is which can be repeatable and which can be teachable. So that any of my students or any of my colleagues or seniors want to use this method, they should be able to do it with very less difficulty and should be able to be reproduced by them. Coming to middle mesial, how to search for it? First of all, the tooth is so small. And then getting those two orifices as a postgraduate in first year, I remember my old days, getting a mesiobuccal and mesiolingual or a MB and a distobuccal was a big task. And now if someone told me search for an MB2 or search for a middle mesial, I would be like, okay, I think I need a magnifying device, or I have to. If you see my hands, they are very fat. So I call myself a crocodile hands. So it's very tough to work in that small area. But then once I'm under magnification, I clear this isthmus with ultrasonics. I have enough space to see. My hands are not clogging the area. I have enough space to see, and I know where to look for a middle mesial. I would not take a DG16 or a sharp probe or an orifice opener and search and hunt for it and create myself. So if you've read a few recent articles where they have mentioned that most of the times we end up creating a canal orifice, which is again merging to one of them. One more thing which I want to add is not always your mesiobuccal is round. I would say they are never round. Yes, they would be oval, but here if you see, they are teardrop shaped. So in this case, what we would do is we would make two orifices and pack in all the necrotic debris in between. So this patient would be asymptomatic for a few years and later come back, and there would be a lesion only in the mesiobuccal canal. Why? Because we did not see the orifice shape and we prepared it in such a fashion that there were two orifices and we packed in all the necrotic debris in between. So the failure was creating an extra canal which is not there and not cleaning according to the 3 dimensions of the tooth and the orifice. Next case is again an interesting case. This is the upper right second molar, if I'm not wrong. There is caries. We remove the caries, do a pre-endo buildup, put a rubber dam. Here, what I do is I get to see only two canals. One is buccal and one is palatal, but I'm sure there's this gut feeling in me which told me that there is another one. And with microscope being there, I put in my hypochlorite high concentration. See the bubbling action happening here. And I'm very clear, yes, 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 yes. I am going to have one more canal. And if you see in this image on the left, The canals are deep down. I would say they are, and if you see the image on the right in the RBG, you would see the division of mesobuccal and distobuccal is at a very, very low level. That is around 5 to 6 mm from the orifice level or the floor level. So hadn't I used magnification, I would only be lucky in getting a catch or getting a file moving in a different direction, but I would never find it. So with magnification, yes, I'm telling the patient, I am going to see what is there. Another case which this happens to all the first year and beginning of second year MDS graduates or postgraduates or people who are into their first 2 years of practice. These days, if you see the first molar here, they see the chamber being hazy. We know it's calcified, but with magnification, you can see the color change. You can see when it is dark gray and when it is becoming clear. So if you read your textbooks well, you would know how the color change is happening and how we can locate the orifices. Another stress which I want to give in this image is see the palatal. It is bean shaped. It is not round. So make sure you don't create two orifices and say there are two palatal canals merging apically. No, you are creating them. You're not cleaning the isthmus. The isthmus was packed by dentine debris. And in the RBG, it looks, wow, beautiful. 1:1 classification, amazing. No, that was not the reason. It was you who has packed in debris there. Cases of open apex where you get to do retreatment. See the one on the right, I have given calcium hydroxide. Now what we do is we take a plugger, put a stopper, take an X-ray and see where it is fitting. Okay, but then if I could show you the apex deep down, yes, this is my apex, this is the length, and this is how I need to pack. I would not have my MTA. I would not even need a barrier to be placed, to be very honest. I don't use barriers most often in my cases until unless it's totally a blunderbuss canal. Otherwise, if it's quite tapering, I don't need a apical barrier because I'm able to see what I'm doing and I have the lens ready with me. So I pack it well, take intermediate RVGs and go ahead and get the outcome. So in these cases, I'm not showing you what good work or different work I'm doing. What I'm trying to show you is your perspective and your imaging and imagining power increases once you start seeing things. And this is not tough. With practice, even you'll be able to do it. If I can do it, I'm sure all of you can do it. There's this case of calcified canal. We took a CBCT. In the CBCT, we realized that there is canal presence only in the junction of middle and apical thirds. So I usually don't go with the reports. I check the whole CD myself. Here, if you see the point of exit is not same as the radiographic apex. So this is one small thing which will make a lot of difference when you're taking a post-op RVG. So what do I do here? Check the CBCT, go ahead. Now, isolate premolar to premolar because I want enough space to work. I like a lot of space to work. Now, I take my burr, make sure it is along the long axis of the tooth, give a punch cut, go along the long axis. If you see now, my burr is exactly along the long axis, parallel to the long axis, right in the center because I know where it is. From there, I shift to a Messinger burr again, and I know at what level I'm going to find. So I just give these brushing strokes there. And I know I'm not going to inadvertently cut any tooth surface. So yes, I feel there is color change happening there. I think that from calcification, I've moved into canal. I would put my tenement file. There's the catch, and there it goes. There it goes. 1 second. I get back to the last slide again. There it goes in. And yes, I take my working length again. Take my master cone. If you remember, the point of exit was separate from the radiographic apex. So see here. So once we have obturated, we get this. Now what you need to pay attention here is where I went wrong. Again, still I went wrong. Where did I go wrong was in choosing my axis burr. I shouldn't have used endo axis number 1 burr. I should have used a 0 size burr. I wouldn't have had even this 0.1 to 0.2 mm of loss of dentine inside. So every mm of dentine saved is doing justice to your tooth. So this looks good to you. You wouldn't have noticed this, but I am showing you, yes, retrospectively, when I analyze my cases on my own, I can improve my work. This is how it helps me. self-analyze and do things better. Cases like this, where there's a fracture, you can actually show it to the patient. Patient agrees to it because they can feel it. But what about fractures like this, which are running from the crown deep down to the floor? What do? You take snaps and you show it to the patient. Sir or ma'am, this is not going to stay. This is the reason we are not doing it, and we will not be able to do it. Or if there is a chance to save it, yes, I put an MTA, make a bigger groove, take a CBCT along with it, and come to a conclusion. Yes, if I do this, the clinical outcome is going to be this, and this is how it is going to work for me. Another case of retreatment. I'm trying to show you all array of cases so that your mind opens up today. So even when you're removing the crown, I do a split dam technique, give a slit to the crown, buccal slit, remove with the hoof 3D elevator which you have for crown removal, change the rubber dam once the crown is out, then go into the chamber, search for, if there is a lot of GP that shows that yes, the referring dentist didn't go well into the canal. But the only thing which troubles me is if the canals are virgin, it's good, but if they have caused ledges, it's going to take a lot of time. So don't commit to the patient that within 60 minutes or within 1 hour or within one sitting, you'll be able to get through it. So we go ahead, clean, remove the GP completely, irrigate, dry it, check for master cone, and do our continuous warm compaction. And always take X-ray in 2 angulations to see how well we have fared. Simple case for anyone of you to do. It's not that only I can do it, all of you can do it. So last part of my presentation, which talks about management of separated anodic instruments. This is one thing which I'm sure everyone was waiting for, and this is my forte, which I love to teach and to share my knowledge about this with my colleagues. And there is a beautiful article given by Madrati which talks about the scheme of deciding what to do and what not to do. I'm not going to discuss this. I'm just going to get to the clinical aspect. For example, here, seeing this X-ray, you should understand what went wrong. First thing, I am seeing a lot of sealer and I'm seeing a lot of radiolucency in the coronal chamber. That means, number 1, the pulp stone was not removed. Number 2, there was no straight line access. So what happens is the file keeps going around the calcification and you're having a lot of cyclic fatigue to the file. And that is why this file broke. The next question is, I try to bypass it first. While bypassing it, I hunt and locate for the file here. And I can see the file which is seen there. But another thing which is visible to me under magnification is it's on the danger area. It's on a dangerous curve. If I remove this file, the remaining dentin thickness is going to be minimal, or there is going to be a strip perforation. So what is the next thing which I can do better for my patient, along with documentation and showing him this later, is I bypass, give calcium hydroxide dressing for a week or 2 till it's totally asymptomatic, take my master cone and obturate and send it back to the referring dentist. This is a 2-year follow-up which I have, totally asymptomatic. The lesion is coming down completely and I have no issues. But back of my mind, I know, yes, just because there is an instrument, don't think you have to go hunt it, take it out. It is not venom. As long as it's not causing problem and you can bypass it and you're able to close the cylinder of the tooth, that is your apical and the orifice, everything is taken care of. Oh, this is an interesting case. 2018, this patient came to me. She resides in US. And 2019, again, she comes. The radiograph looks nearly the same. There's nothing wrong, but the patient complains of pain now. So what we do, we go for a CBCT. And if you see in the CBCT, there is discontinuity in sinus. So what our 2-dimensional RBG was not giving me, the CBCT gave me. But sometimes CBCT is exaggerative again. I'm sure all of you would agree with so many of metal fillings and crowns being there, it could be exaggerative. So what we try to do is, I went through the crown, tried bypassing first. That's my first goal, that I get to know, yes, there is space around it. We bypassed it, we could remove it. But what I found was there are 4 instruments. So what could go wrong here and what could go right here is, if I'm using any used instrument or if I'm giving a lot of torsional fatigue without pre-curving my files are going to break again and again. And if you see on the coronal aspect of the apical thirds, you will see a blunt instrument, that is your ultrasonic tip, because this has been tried by one of our colleagues without magnification. They were working blindly. So it made my life that much more difficult. So if you see the RVG on the left now, there has been minimal cutting. And usually before, what used to happen was, if there is a curvature, we were cutting too much on the outside. But with this advent of teriyaki tips and katana tips by teriyaki, getting instrument in a curved canal is much easier than a straight canal, which is hung there. People who have been using katana tips or the teriyaki kit would agree to me, who've been using it for more than 50 cases. They would know it for sure. Another case, which was an endoperio case. This was sent for a endo treatment. One of my students broke a file. This is one of my favorite students. She broke this file there, and then without the rubber dam being there. See the audacity that they're shooting it without the rubber dam. And then I tell them to put the rubber dam, and then this is a Silo microscope, a global microscope if I'm not wrong, and that the screen was not working. So what we did, we took a phone, we made it parallel to the eyepiece, and we took a picture. And you can see clearly that seeing the cross section of the file, it looks like a pro taper. And I made sure that my student gets it out and not me. And to my happiness, she was able to retrieve it for me. And that's how it goes. And it was referred, it was obturated and referred back to perio department. Yes, we did have a lot of dentin removal in this case. Now, in this video, what I'm trying to show you is I have done a split dam technique. And here I'm trying to show you, I'm using a zero size mirror. I'm having an ultrasonic tip. Why I do split dam technique here is because I want my mirror to have enough space to move back. I don't want the wing of my clamp to be hitting. And still it is being very cumbersome for me to focus in the mirror at the tip of the instrument and my tip of my ultrasonic tip. So there are a lot of students who say to me, we don't want to learn anything. We just want to learn instrument retrieval. I would say it is like going back to your first year, learn how to make a plaster cube first, and then we would teach you how to make a restoration or a root canal. So here, my aim is for you to see how difficult it is. See, I'm struggling. These are my initial days that I'm struggling to get to the orifice onto the file tip to create a staging platform. I will just take 5 more minutes to finish my presentation before I get a big ping sound for delaying my presentation. This is again a tooth which was referred for removal of instrument in distal canal. If I'm not wrong, this was 7 years back. I could remove this. It gave me immense happiness because what we did, we removed the caries. I'm showing you the pictorial representation. Did a pre-endo build-up, removed dentin in the buccal and lingual direction because the canal is oval. Don't work in mesodistal direction because you will lead to strip perforation. We could isolate the head of the file, created a staging platform, and with ultrasonics, it was out. So was this a success or a failure? I show you this RVG and say, at that time, 7 years back, it was a success. But if I do this case now, I would call it as a failure because the amount of dentin which I have removed in and around is, though I have tagged it with MTA, I don't care. Still, I would call it as a failure because I want to keep it as minimal and as conservative as possible. Like in this case, in an extra root, there is an instrument fracture. So in this case, 6 years back again, I'm doing a sectional rubber dam placement here, split dam technique, not a split one. I put EDTA solution in the canal and I activated my tips. And because of lubrication of EDTA, it came flying out. Even I was not sure that this would happen. And this is what is getting published now about using different oils and reducing the surface tension. So this was done long back, and I'm quite happy about that. This is actually what I thought could be is being into a research process now, and the instrument was out. So this case is again a very difficult case, and this is instrument beyond apex in the distal, and this is basically because of mere negligence and inadvertent use of instruments. So we take a CBCT, we decide how far it is, where it is. Again, pre-endo build-up, isolate, put calcium hydroxide or gauze pieces, or you put Teflon tapes to the other orifices so that it doesn't jump and get into them and make your life more miserable. Take angulation x-rays, try bypassing it first. Next, create a staging platform, locate the head. Create a staging platform, make sure again it's visible, it's a pro taper, and then I use a micro tweezer by this Zoomax and then pluck it out. So what went wrong here in this case is point of exit. I will repeat again here. I'm sorry. I get back to this slide. Just show you the video again, and then we close down in some time. What I want to show you here is this. This image is of most important to me. So this was the point of exit created by inadvertent use of files, giving apical pressure, overuse of files. That's why it broke there and went beyond. So this was the actual point of exit. And this is very much appreciable in the next slide. So if you see, laterally, they broke the file because they created it, but it was actually ending 2 to 3 mm short of the radiographic apex, and which is quite evident and clear in CBCT to me. So trust your apex locators, trust your instincts too, and make sure that things become better. So this one of the last two cases which I'm showing you where there are 2 files broken. Upper file, we got it out using the extractor, then the lower file, see there, I am isolating the file, making sure I have created a staging platform, removed enough dentin around it, and when I activated it with ultrasonic, it became loose. So if you see in the video, it looks that, see, I'm trying to focus that, trying to hold to the micro tweezer. Yes, it's loose. So I need something like a loop device or a extractor device which will help me to get it out. With loops, it's a little cumbersome to, it's like playing the ring game that you have to throw the ring around the object to get it. But with the micro extractor, you just get it open, take it there, and get it out. So this is how it just, I could pull it out. See, finally it's out. There it is. 1, 2, 3, it's out. And we go ahead using this micro. And if you see the amount of dentin which is lost here is more in the coronal fragment than your apical fragment. It used to be the other way around before. So if you work on the inner curvatures and give it actually what you call unwinds the file and it makes it pop out. It might look fascinating to you, but it's just common physics and mechanics if you apply there. And if, again, I would repeat, if I can do it, I'm sure all of you can do it. You are more, you have better dexterity than me, and you are the new generation who understands and adapts technology better than me. Okay, I would skip this again. I would come to the last few slides because I'm running out of time. So this perforation case, I was not in favor of removing it because the distal wall of mesial root is not there. There is no floor. The perforation is huge, but we ended up doing the observation, taking a consent that yes, patient is ready for this treatment and knows the consequences. And this is again 7 years back. We put off a lot of MTA, and then I used to trim the MTA because we did not have this putty MTA like what we have now. Things have become easier. Immediate after obturation, this is after 6 months, and this is after 1 year. If you see the amount of resolution of lesion happening, and the patient has his tooth still in his mouth yet, till today, it's working well. So sometimes the nature can surprise you, provided you follow ethics, you follow basic protocols, and make sure you take consent that yes, he or she has been informed, that you don't get dragged to medical legal case later in the court. A referred case where they were not able to locate the distobuccal canal, I always take my pre-op first because I know they would have played around with the tooth. If you see here, there's a broken instrument there, which is quite visible here. And after this also, I was not able to locate. So I sent this case for a intermediate CBCT, and I could see that if you see the number 1, that's where perforation, that's where we were heading. And number 2 is the one where the canal is, and the canal is at the junction of apical and middle thirds. So even if I'm using loops, I wouldn't have been able to locate it. So if you see the slide on the right, that is CBCT to the rescue. 1 is perforation site, 2 is the place where I have to look for the canal. I change my orientation of my ultrasonics, get away with the perforation, locate my distobuccal, bang on, I get it, put MTA, restore it, and the patient is doing well. Send back the patient to the referral dentist. And that's from the right to the left we have reached. So the take home message from my presentation today is magnification will make you see things better, will help you identify things better, give you better diagnosis, will make you have a white collar, which is like surgeons rolled up, and people will look up to you for doing tough cases. And they will not say that you're lucky, because doing this kind of cases once or twice is luck. But doing it repetitively with good clinical outcomes is a practice, and it's your skill. You will develop your own techniques and tricks, like how I developed over a period of 9 to 10 years of instrument retrieval. You will document them better, your patients will be impressed, and they would be wanting to get treatment by you, and you can charge well. Trust me, you can charge well. And like today, I can discuss these cases with you, and over here, I can, whatever I had learned, I could teach you today, and whatever I have taught you today, I will learn back again during question and answer session. So coming to the end of my presentation, this is Arvindal College, where I have done my graduation, where I got my basics right. And I'm an alumni of Meenakshi Ammal Dental College, Chennai. And this is a place where I did my post-graduation. And I would say this was a place which changed my life completely, from a notorious student to a sincere student toward my work. And this is in Germany, where I got my advanced training for working under a microscope, because I was not quite sure that what I'm doing is right or not. And College of Dental Sciences and Hospital is a place where I teach a little, whatever little I know, to my students, if they want to learn from me. And this is where I practice. But one thing you should not forget and not get carried away in this present scenario is this slide, which I always like to say. It does not depend on how many instruments or gadgets you have. If you do not know how to use them, they will never be enough. So if you give me a Ferrari car, I will not become a Michael Schumacher till I practice and use it the way it is supposed to be used. Same way in this slide, he's having so many ladders and he's making a heap of it to climb and see on the other side. Whereas he can just take one ladder, put it against the wall, and climb and pass through. So understanding what is in your purview is most important. So this is the ideology of my life and dentistry: is learn and then teach. And then when you're teaching, you get to learn more. So never forget this. And I would like to thank all my teachers, mentors, and friends. And to my surprise, God has been very kind to me from I would say forever. And today, the star of Endo Galaxy is going to be Suma Balal ma'am, who is my postgraduate guide. And during the post-graduation, I used to be a nervous kid, I would say. And she was the one who always made sure that I don't panic, I stay calm, I stay focused. And the whole team in the department, Bail Murugan sir, ma'am, Hima Malti ma'am, and all the other staff members are the ones who have made me today what I am. So any doubts and queries which you have, you can take down my mobile number, my email ID, Facebook account, Insta, or YouTube. So now coming to the tough part, that is taking up questions. I hope I didn't disappoint you all.
Thank you, sir. That was really a great presentation, and it will change our perception towards the use and application of magnification in dentistry. Thank you once again, Anuj sir, for enlightening and truly informative session. Now I request our moderator for today's, Dr. Pradeep sir, to take up the queries from the participants.
Thank you, Dr. Gautam. That was indeed a wonderful lecture, Dr. Anuj. I would like to congratulate you on covering almost every aspects and touching the basics of the magnification. And what is important is that after listening your lecture, why one should not adapt to the magnification. That is more important. So all credit goes to you for such a wonderful job you have been doing for the endodontic fraternity. There are certain questions which I think I should take it right now. Okay, yes, Dr. Anuj, are you able to listen me?
Yes, I can hear you, sir.
Okay, so I'll take the questions. Yes, I don't know the question is from whom, but the first one is, how often should we perform parfocalization, does it have any effects on the eyesight? That is the
Oh,
first question.
perfect. That's a wonderful question. And first, before understanding that we should do parfocling, what I would want to tell is what is parfocling? Parfocling is that at highest magnification, you set the field of view, and then when you change your magnification changer, you don't have to move your microscope up and down. That means that you have a fixed focal length decided at highest magnification. So now coming to, there is forward parfocling, there is reverse parfocling. So I would not get into the details of the two. What I would say is make sure your microscope is connected to a screen on the top or on the left or on the right. Put the rubber dam on, take your microscope at the highest magnification, keep talking to the patient, holding the microscope in left hand or right hand, just focus the tooth and keep seeing in the screen, not in the lens. And the time it gets clear, it's parfocling is done. And it is very important so that you don't keep moving up and down. But with the advent of newer technology or your varioscope, things have changed. So this parfocling is important. But if you have your varioscope, I would say use varioscope only once you become a pro with your fixed focal length. So parfocling is important. It does not affect your eyes, provided you're doing it on the screen. It works well. And reverse parfocling would be is that you start from lower magnification, go to the higher magnification, and set the working distance. So there you lock it off. You don't have to keep moving it up and down. And those final adjustments can be done with your finer focus or your varioscope. I hope I have answered the question.
Yeah, thank you, Dr. Anuj. There's another one. Sir, what is your take on using the magnification loops while wearing the face shield in current COVID-19 scenario?
You will have to
I'll
just
repeat it, sir.
yeah.
Sir, what is your take on using the magnification loops while wearing the face shield in current COVID viral scenario?
You should use it. What I would say is put your face shield onto your frame of your loop, cut those two holes, and make sure the lenses are out through those holes. And then you seal that with a tape or with any device which will make sure that there is no leakage happening. A lot of people are doing that, and you should use a loop. Don't think twice. In fact, you're going to do a better job and a faster job if you're using loops during these times. So that's another lecture which fascinates me, that you should use magnification during COVID time, because you're having that much of a distance to work and you're doing a better job than the rest, and faster too.
Yeah, that's perfect. It will surely will keep you quite away from your patient if you're working with the magnification. And the another question, Dr. Anuj, sir, what is your protocol for disinfection of microscope and its lens per se during COVID times?
Perfect. I so knew it that it is going to come. Can I have share screen again? Yes. Okay. Let's not talk. Let's show it to you. Okay. So I have a cling film, which is a bigger cling film, industrial grade. I've removed the camera on the left so that you can see it. And if you see my microscope, it has a blue cap below that is autoclavable. And I have put this cling film all around. And nowadays you're getting surgical drapes also, clear surgical drapes for microscope. But that would turn out to be too expensive. But if you use this cling film and keep clinging it everywhere so there is no leakage happening, and if you have your lens mount, which I'm showing you here, the job is done. Nothing to worry. I've been doing this from last 1 month since I've started my practice back again.
Okay, thank you. The last one,
Yes,
Dr. Anuj, the last one is, what is the stereoscope effect?
Okay, stereoscope effect is when you're not able to see things in the manner which it is supposed to be seen. The third dimension is lost. So I would want you to understand that third dimension has to be seen always. So that's what I would like to say.
Okay. I think that's all. No more questions, Dr. Gautam?
It is okay.
Yeah, all the questions are being, I think, nicely answered by Dr. Anuj.
I would like to add one more thing, sir. What happens is when you're using, like, coming back to the stereoscopy again, uh, it's something like RVG again. I want to explain it in detail to you. Uh, there's a difference between RVG, CBCT, and the object is three-dimensional. So stereoscopy would be that you're getting a flat image, but I would want a depth of image. So if you had seen all my images, they looked flat because they are an image of an three-dimensional object giving a 2D image. Basically, stereoscope is you get to see the depth of it. You are supposed to see 3 dimensions of it. So if you are using a 3D TV and I'm showing through a 3D microscope, you could see it. But when I'm using a microscope and working, I would of course see 3 dimensionally because my eyes are 3 dimensional. Another thing which you can do with your images is something called as stacking. You can take images of the same plane at different depths using a fine focus and stack them together around 30, 40 images, and you would get depth of field also. And that would give you a 3 dimensional image. I hope this is what they wanted in the stereoscope image, the depth being seen.
Okay.
Yeah. So I misunderstood the question. That's why.
Oh, thank you, Dr. Anuj, for such a wonderful lecture once again. And I'll hand over the mic to Dr. Gautam and Dr. Pratima.
Thank you, Anuj sir and Pradeep
My
sir.
pleasure.
On behalf of Department of Conservative Dentistry and Endodontics, we like to give certificate of appreciation to our speaker, Dr. Anuj Bharadwaj sir, and moderator, Dr. Pradeep Jain sir.
Thank you.
We also conducting a mask kit selfie with mask contest. So kindly send your entries for the same before 25th of July, and details are on the screen. These are some few entries. So kind send your unique selfies with innovative ideas.
Okay, that's great.
Apart from the academic activities, we wish to highlight those individuals in our specialty who have enriched their lives with the other co-curricular activities as well. We as a specialty have a constellation of endostar in our galaxy. Let's look at one of them. Today we have our endostar, Dr. Suma Balal Rao Madam. She is a professor, Department of Conservative Dentistry and Endodontics, Meenakshi Amal Dental College, Chennai. She is a multifaceted personality with interest in music, dance, and adventure travels. She has started her own cookery channel in the name of Dr. Suma Rao, demonstrating simple, easy, and healthy recipes. So let's watch her non-academic achievements. I request Dr. Mohit Gunwal to propose vote of thanks.
On behalf of the Department of Conservative Dentistry and Endodontics, VSPM's Dental College and Research Center, Nagpur, I would like to recognize the efforts of our guest speaker for today, Dr. Anuj Bharadwaj sir, for sharing his expertise with all of us. I would also like to extend my heartfelt gratitude to our chairperson for today's scientific session, Dr. Pradeep Jain sir, for sharing his valuable time. Thank you to all senior faculty members and participants for joining us today. See you on Monday, 11 a.m. with yet another informative topic on Zoom. With your due permission, I would like to end the session for today. Have a great day ahead.